हेलो। अच्छा ठीक है। हाँ। अच्छा ठीक है।
Hello, am I audible?
Yes.
Yes, sir.
Hello,
Yes, sir.
hello,
Yes.
hello, and good evening to all. On behalf of Bharat Technology, I would like to welcome all the participants for today's session, a national webinar on common clinical problems of ENT. We have successfully completed a various number of webinars in last year. From now, we are going to arrange a series of webinars in this year. Today is the first one of this webinar series. And now I would like to introduce myself as a moderator for today's session. I, Dr. Gunjan Sharkar, Associate Professor of Bharat Technology, Uluberia, Howrah. And now I would like to request Assistant Professor of our institute, Mr. Omlan Biswal, to please share the overview of our institute in a screen. Thank you, Amlan sir, for sharing this informative video for us. Now, I would like to introduce our Honorable Chairman, sir, Professor Dr. Rabindra Devnath. Professor Devnath, sir, is a renowned personality and entrepreneur in the field of pharmaceutical science. Now, I would like to request Honorable Chairman, sir, to share his valuable thought about today's webinar. Over to you, sir.
Hello?
Yes, sir.
Hello? Can you hear me?
Yes, sir. You are audible, sir.
Yes, sir. It is.
So on the auspicious day of Bharat Technology, that is to 28th evening, you have organized a seminar on clinical aspect of ENT. We have invited our renowned speaker, Dr. Subhashasi Chakraborty. He is a very renowned in the in the treatment of medicine and also professor and ENT. He got the degree from India and abroad. He has got the more than 40 years of experience in the field of teaching as well as practice. Now, question is why one get the disease? Why get the disease, and what are the cause of the disease, and how it will be overcome? These are the important aspect we will discuss here, and how to overcome this one. It is the case there. ENT is a very important junction of our many organs in the body, brain to heart, and brain, lungs to mouth, eye, nose, ear. These are the very sensible organ. Each sensible organ is exposed in the air, exposed in the outside. So there is a chances of many cause of infection, inflammation, many disease may be occur. It depends upon the personal hygiene. It depends so far as I know, and also good living practice. Good living practice is also important. In my personal case, my wife was suffering from tonsillitis. The ENT tonsil to be brushed up at any moment. Dr. Kishore, surgeon at Agartala Hospital, he told that immediately operation to be given, operation to be done. So at the end of the December, we had a conference in Bombay, IPC, Indian Pharmaceutical Congress. On return journey, we go to the Belur, Christian Mission Hospital. Then only 100 rupees we have to pay. That is directly specialist can be consulted. After consultation, he asked us some the daily routine and biodata, what is happening there. Then he requested that there is no need of any medicine. You go to the home and will be safe. It is a allergic base. Whenever she want to go to a new environment, new season, etc. Morning, evening, gargle, only gargle is necessary. Nothing else. Now, still now, after 40 years of our marriage, so she is arriving without any ENT problem. So, this is the prevention is better than cure. But if it is there already, we have to cure it. So in healthcare system, there are in one side doctors, another side pharmacists, and another paramedical staff, nursing. There is a golden triangle. In this golden triangle, is any bar, is anything is disturbed, total system will be disturbed. You see, what a serious thing. Vaccine is given to increase the immunity power. Now, vaccine also there is a smuggling or impure medicines and impure dose is given. So in this aspect, our pharmacy and pharmaceutical personnel have a moral duty to supply the pure, safe and rational medicine to the patient. A patient does not know details about it. He may be lawyer, he may be engineer, he may be multimillionaire, he may be businessman, or he may be business country, business developer. So regarding disease, will be diagnosed by the doctors and our supporting staff, and it will be prescribed by the medicine will be prescribed by the doctors, and administration also will support by doctor, doctor, paramedical staffs, and the pharmacist jointly. So in this way, a total healthcare system in the system, pharmacists and pharmaceutical personnel have got a great role. Now, the COVID situation, everybody is rushing for the design and fabrication of the COVID medicine and vaccine, etc. Now, where is a continuous work, continuous dedication is there, there will be success. The immunity. One fine morning, you there, you get that India is leading to the world, and our active, our expert, doctors, pharmacists, etc. Those have already migrated to other countries. They are also returning back. So whatever the resources given by the Almighty God, from river to forest, river to forest to desert, this is diversity. With the diversity, there are various sources of the drugs. These sources of the drugs to be properly identified, properly analysis can be done, then it will be used for the human maintenance. These are the main dream of our pharmacists and pharmaceutical, and they are associated with the doctors, other paramedical staffs. Now, clinical trials, clinics is one of the important aspect of the pharmacy. So whenever in clinics, one in the doctor's chambers, when patient is come, it will come directly to the patient, and their studies will be there. In my, I'm from TCC, you might be finding, I was handling the leprosy patient who designed the anti-leprotic drug. So depending upon the physiological, pathological condition of the patient, pharmacist has to design the drug, fabricated drug. Doctor will used to administer the drug with constant supervision of a medical and paramedical staff. So our design and fabrication and the dosage form will be such that it is non-toxic or very toxic or more effective. This is only possible with the help of dedicated work, with the help of scientific reasoning, and the patient also will be benefited, and in this way our India will be again leading to our international level for maintaining good health of the patient and health staff. Thanking you. I hope this seminar will be a good one. Uh, student staff and other paramedical staffs also will be benefited. Dr. Sabyasachi Chakraborty will deliver a beautiful lecture for us. Thank you.
Thank you, sir. Thank you, sir. Thank you for enlightening us with your valuable thought. And this is very informative speech. And now I would like to request our Honorable Principal, sir, to share his remarks for today's webinar. Over to you, sir.
Good evening, respected Chairman, sir. Today's eminent speaker, Dr. Sabyasachi Chakraborty, sir, and respected Dr. B.B. Barik, sir, who is present today. You can see our Vice Principal, sir, my dear colleagues, students, and all the participants. It is really a pleasure, good evening, or you can say that we can gain a lot of knowledge from Dr. Sabyasachi Chakraborty. We are eagerly waiting for his valuable thoughts. As sir told that pharmacist and doctor hand to hand, we have to work along with the nurse. Then only we can achieve our goal. Regarding our college, I can say that Bharat Technology, it was established in 2006. From that time, it is making student. We can say we can giving a lot of students are already completed their degrees. Not only degrees, they are well knowledgeable. Whenever our students are going, that is our main positive things that they are getting a lot knowledge. And knowledge, definitely we are trying to give our students the best knowledge. But apart from that, if expertise come from outside also, definitely it will give the better knowledge to our students, to us also. We can gain a lot of knowledge. If I quote a movie's dialogue, that is Three Idiots, whenever जहाँ पे कुछ भी knowledge मिले तो उठा लो. So really, it is a good opportunity to gain the knowledge. So as a COVID situation, it is much more easier that we can sit our house, and by sitting in our house only, we can gain the knowledge. We can gain from these eminent speakers. Last time we have already conducted more than, I think, 10 seminars, webinars. So our student can achieve their knowledge from this webinar. That is our main motto. I'll not take much more time. I'm waiting for this Dr. Sir to tell something about this ENT, or to say clinical problems of ENTs. Thank you. Thank you. Over to you, sir. Gunjan, sir.
Thank you. Thank you, Professor Kuntal Hajra, sir, Principal of Bharat Technology, Uluberia, Howrah. And thank you for sharing your remarks for today's webinar. Those who have joined just now, I would like to welcome once again. Now, I would like to invite our Honorable Vice Principal, sir, Dr. Biplab Debnath. He is a renowned person in pharmaceutical field also. And now I would like to request Dr. Biplab Debnath, sir, please share your valuable thought for today's webinar.
Thank you, sir. Gunjan, sir. Very good evening, all delegates. It is my great pleasure to extend a warm welcome to Bharat Technology to this on clinical problems of ENT, which has been organized by Bharat Technology Department of Pharmacy. Bharat Technology, among the leading educational institute of West Bengal, aiming to provide quality pharmacy education to students. Bharat Technology was established in 2006 and approved by All India Council of Technical Education, Pharmacy Council of India, and affiliated to Makaut, Kolkata, and West Bengal State Council in Technical Education. Our institute is having a state-of-the-art facilities to provide the need of pharmacy curriculum for UG, PG, and PhD program. Biotechnology's online webinar series to spread the knowledge on health and pharmaceutical sciences continues to be on roll. We will continue organizing such a webinar sessions, so please stay tuned and join our Telegram group for more. Being the convener of the webinar, I, Dr. Biplav Devnath, I would like to declare that the webinar is now open. I am delighted to welcome all the distinguished participants today present in our Professor Barik sir, Professor Dubajyoti sir. I am thankful to the expert for accepting today's webinar invitation from his busy schedule. In particular, I would like to express my gratitude and warm welcome to our eminent speaker, Dr. Sabyasachi Chakraborty sir. I would like to express my heartily welcome to the patron of the program, Professor Rabindra Devnath sir, and today's chairman of the webinar, our principal sir, Dr. Kuntolajra sir, and coordinator of the program. I wish to extend my deep appreciation to the Bharat Technology webinar team for their immense help, support, and dedicated efforts to fulfillment this webinar series. While I can't mention each on Bharat Technologies team by name here, I hope that they will take this as a personal thank you. Thank you, everyone. Thank you, Gunjan
Thank you.
sir.
Thank you, sir. Thank you. Thank you for sharing your remarks for today's webinar. Now, this is the time of the main attraction of today's webinar. And now I would like to invite, and I would also like to request our eminent and honorable speaker of today's webinar, Dr. Sabyasachi Chakraborty. Dr. Sabyasachi Chakraborty is an ENT and otolaryngologist, and he has completed his MBBS degree in the year of 2012. And also he have completed MS in ENT, that means ear, nose, and throat. Dr. Sabyasachi Chakraborty is an eminent ENT head and neck surgeon of otolaryngologist with Calcutta Medical Center, Kolkata. He has completed his MBBS in the year of 2012, and the main flow, his main area of specialization includes ENT checkup, ear microsurgery, and reconstructive middle ear surgery, ear reconstructive surgery, salivary gland surgery, head and neck pain treatment, tonsil surgery, functional endoscopic sinus surgery, ear infection treatment, and hearing deficiency assessment. And he has lots of experience in the medical science field and surgery field. And he has also completed his 13 years of experience in medical science. And he is also a member of Royal College of Surgeons, UK. And he has got gold medal in his Master of Surgery degree. Now I would like to request our honorable speaker of today's session, Dr. Sabyasachi Chakraborty, to share his valuable thought about the common problem on ENT. Over to you, sir.
I hope you can hear me.
Yes, sir. Yes, sir. You're audible, sir.
Okay, thank you, Dr. Sharkar, for such a good introduction. I'm
Welcome,
very
sir.
grateful to all of you for inviting me. Yeah, I am an ENT surgeon, and I've completed my MS in 2011. Then from there, I went to House Ear Institute in UK, which has been a good. It was a year hospital, only year hospital in Los Angeles, and that was a good experience. Then I spent some around 3-4 years in UK, where I completed my MRCS and FRCS. And now currently I'm in Calcutta Medical Research Institute. And we have our own hospital in Howrah itself. It's Nabonir Hospital. Probably quickly share and show you. This is our hospital. So in case, probably many of you will know, this is our operation theater, and this is where it is exactly located opposite to Murjala Stadium, you know. So that's that. Anyways, I have been told to talk about ENT. It is next to impossible to tell you everything about ENT in this short span of time, isn't it? In 40 minutes or 1 hour, it is completely impossible. So what I have done is I have compiled a few slides, and I will show you lots of pictures today, and I will talk on those pictures as those pictures come up on screen, so that you get my view as an ENT surgeon or an ENT practitioner, what I think of these cases. It will not be a lot of information, and not be everything about that disease and things like that. It is impossible to do that. So I'll just talk on those pictures so that you get a view and get an overview of what is what, or the basics of things about rhinology, little bit about nose, little bit about ear, a little bit about neck. I'm just going to talk about thyroid a little bit. So you get a little bit of an overview, and I'm going to leave you with more questions rather than answers. So, all my dear students, who are watching this maybe, so at least they will have questions in their mind, and they'll be interested in ENT or ENT diseases, so that they go back and find out more and learn more about ENT. That is my aim. So let us see, without wasting time, I'll quickly, we will probably quickly go to the slides. Try and share the screen. Yeah, I think this is the one. Can you all see the screen? I guess, yeah, the screen?
Yes, sir. Yes, sir.
Okay.
The screen is visible.
So we will start. So I have named the topic as a bird's eye view of ENT. So it's probably just a very, very small view, but it's a wide view of many things together. Okay, so with that thought, we will start. As I told you, this is how I have kind of organized the presentation. We're going to talk a little bit about rhinology, little bit about otology, that is ear, and a little bit about, it is impossible to cover a lot of topics in the neck part. Like there is, as I heard somebody was saying about tonsils and things. So there are lots and lots of things in throat. So voice, tonsils, head and neck, malignancies, salivary glands, you name it. There are so many important things in neck. But I thought the commonest thing probably everyone would come across is maybe thyroid. So I will talk a little bit about thyroid from the neck part. So that's how I have organized. And as I said, a lot of pictures, and I just talk on these few minutes of talk on all of these pictures. Okay. So we are going to talk a little bit about anatomy for each part of these, and then we are going to move on to common diseases. Okay. So as I told you, it is next to impossible to tell you everything about ENT. Probably it's a lifetime's worth of information, isn't it? So you can spend one lifetime reading about ENT, you will still not be over. There's so much to read and so much to know in our field in ENT, because it covers a lot of things. It covers ear, which is a sense organ, nose, which is another sense organ, tongue, which is another sense organ. So 3 sense organs. And along with that, so many other things in the neck part, head and neck region. It's a lifetime's worth. So you can spend your entire lifetime reading all these books on ENT. And I have been told to do that in 1 hour. It is impossible, but impossible is nothing, isn't it? So we will try and give you as best as possible. So let us see. We will quickly start with the nose. Just brief, again, as I said, a lot of pictures. So I'll start with the anatomy. If you look into the nose, you can see this is the nose. So the outer nose, or the external nose, so this part of the nose, it is made with a lot of bones and cartilages. So the upper part, or the hard part of your nose, is the bone. So you have the nasal bones, then you have a bit of the maxilla. So this is the maxillary bone, the bit of a part of the maxilla coming up and forming a part of the nose, the bony part of the nose, or the dorsum of the nose. There's a little bit of the lacrimal bone at this corner as well. From the top, the frontal bone comes in. And the other, the lower half of the nose, or this part of the nose, it is, you can see it is soft, so that it is not as hard as bone. So it is made up of cartilages. So you can see these are the cartilages. This is the cartilage in the part of the nose. So lower levels, there's a lot of fat. The ala of the nose, this part has a lot of fat. Okay. Now the inside of the nose is the side walls of the nose, you can say, the inside side walls look somewhat like this. There are bulges like this, you know. So these bulges, they are called turbinates. So you have 3 sets usually, or inferior, middle, and superior turbinate. Okay? So this is the lateral wall of the nose. Okay, so this is the side wall of the nose with the 3 turbinates. And you can see that the nose is the floor of the nose. So this is the floor of the nose, is actually the roof of the oral cavity. So roof of your mouth is the floor of your nose, isn't it? And the roof of the nose is kind of the floor of the brain. Okay, so this is the brain. So all this is the brain. So the base of the brain rests on the roof of the nose. So this part we call the skull base. Okay, so it's the base of the brain. It's a very important part when we are operating. We can use the endoscope, and we can actually nowadays do a lot of brain surgeries through the nose, you know. So that's how our ENT is, the field is expanding. It is going into new frontiers. We can operate on brain tumors. We can operate on pituitary tumors through the nose. So the access is, instead of going through the brain, we can go like this through the nose and operate into the brain. Okay. Now this is the middle part, the middle wall of the nose, or the medial wall of the nose. That is the septum. So this central part, which is inside, is the septum, or the partition between your right and left side of the nose. And as you can see here, there are again a lot of bones come in. So this big part, the vomer, and the upper part, the ethmoid, these are the bony part of the septum. So these are the 2 major bones which forms your septum. And as usual, you have the front part, which is soft, and that is the cartilaginous part. So you have the septal cartilage. I'm not going to go into a lot of details because this is not the place or time. I'm going to leave you with a lot of questions. You know, all my students who are interested, they can go back, read about these things. They're very nice to read. So there are so many other bones come in to form the part of the nasal septum, but these 3 are the major part. Okay, quickly moving on. Another very, very important part of the nose, or maybe the nasal, the paranasal system, are the sinuses. We all know about sinuses, isn't it? So, you know, everyone talks about sinuses. If you have a little bit of headache and you say, oh, I have a sinus headache, or I have sinusitis. So what are sinuses? You know, our facial bones, these bones, they are not solid. They're filled with air. Okay, so if this was solid bone, our head would have been much more heavy, and it would have been very uncomfortable for us to carry that heavy bone all around our face. So, you know, it's nature's way of making it light. These are all not solid, they're filled with air. Okay, so a lot of air in these pockets. So you can see here. So there is a big sinus called the maxillary sinus. So this bone, the cheekbone or the maxillary bone, has a big air pocket inside it. The bone between your nose and the eyes, the ethmoid bone, has a lot of air pockets inside it. So they're called ethmoid sinuses. The front part, the forehead, has 2 big air pockets here, which are called frontal sinuses, which would be here. It is not shown here, but which would be here in front of the forehead. And when you have gone back, I think if we go back 1 slide, I'll show you. There is 1 big sinus right at the middle of your forehead down, you know, right, you know, by the vertex of your head. So right here, it's very much inside into your nose. 1 big sinus here is called the sphenoid sinus, and that is adjacent to the pituitary gland in your brain. So pituitary gland is very much close to the sphenoid sinus. We can go through the sphenoid sinus and operate on brain tumors and operate on pituitary tumors. So that's the anatomy of the sinuses. Lots and lots of things here to say, but as I said, I'm just going to spend few minutes. I'm just going to give you a brief overview, just going to touch you with all these things so that, you know, you get more questions and you are more interested to learn. Now, if you look into this sinus picture and look into the CT scan of the sinus, this is one of our main investigation when we are talking about sinus diseases. We get a CT scan of the sinuses. X-rays are also there, but X-rays are nowadays becoming more orthodox. We get much more, maybe 10 times more information with a CT scan of sinus rather than X-rays. So that's become the gold standard or the main investigation in all these sinus diseases. So if you look into these two pictures, I'm sure you can see the similarity, isn't it? So you don't have to be a master in CT scan or anything to see that the anatomy is so well depicted on CT scan. So if you see this, these are the eyes, these are the maxillary sinus, these are the ethmoid sinuses, this is your nasal septum, the partition, these are the turbinates here. And then go to the CT scan, you can see these are the eyes, okay? This is the maxillary sinus. Air, remember on CT scan looks black. So this is air inside the bone. The bone looks white, the air looks black. So this is the maxillary sinus. These are the ethmoid sinuses. This is your partition, the septum, nasal septum. These are your turbinates as we showed on the other picture. See, these are your turbinates like that. So this is your turbinates here. This is your brain. So that the top part is your brain. You can see how close the brain is to the nose, and so it is covered by just a very thin layer of bone. The thinnest part is 0.5 millimeter. Imagine, thinner than a paper. So paper thin bone at the roof of the nose separates your brain from the nose. And we have many diseases where this bone is fractured or there is a hole in that bone, and there is a lot of problem then. Okay, so millimeters or even fraction of a millimeter thin your nose from the brain. So that important. Nose and the sinuses are so important. Okay, now I'm moving on to quickly to diseases. Lots and lots of diseases in nose and the sinuses. But I'm going to touch each one of them very briefly with all these pictures so that you can look at these pictures and you can keep something in your mind that, okay, these were the pictures for this type of disease. Vestibulitis. So I'm starting with the outer part. There can be infections in the outer part of the nose, on this part of the nose, because that part of the nose or the outer part of the nose, which is not very much inside, is covered by normal skin, which has hair, lots of hair, small hairs, and hair follicles or which the hair comes out of the skin can actually get infected, isn't it? So when the hair, you say you're rubbing your nose and you can pluck your hair or something, if the hair is gone, that small hole from which the hair had come out, now the bacteria can go in there and form an infection. You can see that this patient is having a red vestibules, infected, very painful. Often it is staph infection, so Staph aureus, Staphylococcus aureus. Treatment is antibiotics. You will know so many antibiotics are available, probably something which will work on staph, a gram-positive antibiotic, and you apply topical antibiotic ointment as well. Okay, so that's vestibulitis. That is an infection, simple infection of the outer part of the skin of the nose. If I move little more inside, the central partition of the nose, the central partition of the nose need not be in the center all the time. It can be deviated to one side or the other. And exactly like I said, deviation, so we call it deviated nasal septum. So DNS, it's a very common term. You will use many ENT surgeons, or you might be having it. It is said that out of 100, maybe 50, 60 of you would be having a DNS. You may not be having problems with it, but you may be having a bent septum. So you can see this patient here has a partition. So this is the nasal septum. This is the side wall of the nose. Okay, so that's one of the turbinates. You can see how the partition has slanted and gone to this side, and then this sharp edge is called a spur. Okay, sharp projections are called spur. So there is a septal spur as well with a septal deviation. So it is bent like that. And sometimes it might cause symptoms and it may need surgery. We call it septoplasty. Again, rhinosinusitis, a very, very common thing in our clinical practice. Rhinosinusitis can mean a lot of things. It is not just one disease. Okay, remember that. So it is we generally tend to club the nose and the sinuses together as one unit, and we call that rhinosinusitis. Okay, so we don't look at the nose separate from the sinuses, because the mucosa or the skin in lining the nose is actually lining the sinuses as well. So it's kind of a same system, you know, as if the nose has actually gone into all these parts of our face. You can look at it like that as well. So whatever infects the nose actually will infect all your sinuses around. So if you have a cold, common cold, you will feel that your face and your head and forehead and face, all this becomes heavy, and you don't feel well, your head is heavy. So it's not just limited to the nose. So nose and the sinuses go hand in hand. Rhinosinusitis can be different things. It need not be an infection all the time. So you have infective, but you can also have allergic rhinosinusitis. Okay, so when you have an allergy, so you go to a dusty room. Some people who are allergic will start sneezing, start having a lot of rhinorrhea, a lot of mucus coming out, a lot of itching of the nose. So that patient is having, or that person is having, allergic rhinosinusitis. So he doesn't have an infection. Or very commonly, it can be just an infection where it can be acute, which is short-lived, few days time. So you have an acute viral rhinosinusitis, like common cold. So that's a viral infection. Every one of us has got a common cold. The season changes or something, you get a cold. That's a viral rhinosinusitis. If it is little more severe, say you're getting yellow mucus, thick mucus from your nose, it is a bacterial. So probably it is initially viral for the first 2, 3, 4 days, and then probably the bacteria get a chance to infect the nose, and it becomes a bacterial rhinosinusitis. We call it ABRS, acute bacterial rhinosinusitis. Or it might be chronic, and that's a big, huge number of patients suffering from chronic rhinosinusitis. It's a huge topic. Okay, so you can have chronic rhinosinusitis, having nasal polyps, without nasal polyps, and it's a big topic. I can spend hours, you know, the amount of information that is there nowadays, we can spend hours and hours talking about chronic rhinosinusitis. But I'm just touching these points for you so that you know what's going on, what we mean when we talk about these terms. So rhinosinusitis, inflammation, not necessarily infection only. So it's inflammation of the nose and the sinuses. It can be allergic, can be infective, can be non-allergic. So this term NANIPER means non-allergic, non-infective perennial rhinitis. So that is one category where there is neither infection nor allergy, but still the patient has cold-like symptoms. Okay, there are many things in that. Okay, so we'll move on from this slide. I think I'm telling you a lot in one picture. Okay, so little more about rhinosinusitis. This is how we define rhinitis, because this is such an important topic. So I'm spending just a couple of minutes on this. So you will see that it's inflammation. Inflammation means the part lining the nose and the sinuses, the skin of the nose and the sinuses is red, congested, inflamed. Okay, so inflammation. This is the standard definition accepted worldwide. 2 or more of the symptoms should be there. Along with inflammation of the nose and the sinuses, you have a blocked nose, discharge coming out, so mucus coming out. You might have facial pain and pressure-like symptom, or you might have loss of smell. So when you have a cold, you cannot smell, isn't it? So any 2 of these symptoms along with inflammation, we call it rhinosinusitis. Can be acute, as I told you, less than 12 weeks, or chronic if it is more than 12 weeks. So if your cold is persisting for 3 months, 6 months, 1 year, you have a chronic rhinosinusitis. It is not an acute. It will probably not just go away like that with time. So you have a chronic rhinosinusitis. These are the common clinical features of chronic rhinosinusitis. Patients having cold-like symptoms for a prolonged period of time. See, and the one important thing is we have to talk to the patient, listen to their complaints, and the main stay for diagnosis is their symptoms and signs, what we look into the nose when we are examining them in the clinic, rather than our fancy CT scans and endoscopies and things like that. This is another part of chronic rhinosinusitis when you have, and you have heard that quite a lot, you have heard polyps or the term polyp. So these polyps are a part of chronic rhinosinusitis. So some patients with chronic rhinosinusitis will have nasal polyps and they look like this, see? So this is a polyp. Polyp is nothing but the skin of the nose and the sinuses. They get so much swollen that they come out outside the sinuses and they hang out like, see, they hang out like bunch of grapes. They look juicy, just like grapes, you know. So then these are hanging out from the sinuses. The sinuses are inside here. And see, there is some polyp here. There is a polyp there. There are some polyps towards the throat. So as you go down into the nose, you're going into the throat. So those are polyps. There's a polyps here. So they're glistening like this, and they're filled with a lot of mucus and water. And they kind of block the nose because they're taking space. They're not allowing air to go in. And the CT scan will then look like this. You remember the CT scan I showed you, the normal CT scan, which had all these areas were black, isn't it? Black like this. But when they're filled with polyps like this, they will not be black. They'll be this color, gray, which is polyp, okay, which is a lot of soft tissue. Sometimes we need to operate on this. This will play like this. Let me see. When we operate, can you see the video? Are you able to see the video?
No, sir. No, sir.
No. Okay, let me, I don't know, stop share. Okay, I will share the video screen with you. Just bear with me. Can you see the video now?
Yes, sir.
Okay, so when we are operating, say we are operating on the nose and the sinuses, this is what we do. See, now we are operating on a nose. As I told you, there are the turbinate. So this is the inferior turbinate, that is the middle turbinate. And this side is the septum, the partition of the nose. I'm injecting something. I'm injecting a local anesthetic agent. You all know what a local anesthetic is. Xylocaine. It can be mixed with adrenaline. So this was a xylocaine with adrenaline solution. And see how we operate. We have a camera in our hand, and we are seeing this operation on a TV. We are looking at this on a TV screen, and I'm not looking into the nose and operating. I'm looking at the screen and operating. So you know, so you can see we have packed the nose with a lot of adrenaline-soaked patties, and that is the throat there. And this is the partition of the nose, which is separating into right and left side. That's the throat. And all my sinuses will be in the place where my gauge is. So this gauge, this place is where the sinuses opening are. I'm not going to show you the entire video. So you can see that I've gone a little bit forward. So what we do is we use our instruments and gradually, step by step, I open. See, this is the middle turbinate. I have already opened one of the sinuses. So this opening is the maxillary sinus. See how we have opened up a little bit of the sinus. I'm opening up little, this is called the uncinate process. Okay, so that is the opening of the sinuses. It's like a door which is covering the sinus openings. And that's the maxillary sinus. You can see the hole there, my suction going into the cheek kind of. So the suction is like that, it's going in there. Okay, so I'm not going to show you the entire video. So let me go back to the presentation now. Can you see the presentation now?
Yes, sir.
Okay, good. So that's that. So that's how sometimes we need to operate on the sinuses, and that is called FES, endoscopic sinus surgery, FES. So that is also a very common term you will hear in our rhinology practice. We do a lot of operations, septoplasty, FES, and all these are very common things. Okay, so allergic rhinitis is another big bulk of patients. Many patients are allergic, and they have, they come to our clinic with sneezing, nose block, rhinorrhea happening almost every day. They can't go out. If they go out, say if there are pollens or things in outside on a ground or something, they start sneezing. They feel bad. They have itchy eyes. Many of you will have it as well. So you all have experienced it sometime or the other. But if it happens on a regular basis, almost every day, it is a trouble, isn't it? So it's a big bulk of patients. They have this sneezing, itching, rhinorrhea, or mucus coming out of the nose. and their nose looks like this, or their turbinates are swollen and bulky and almost pale bluish in color, lot of mucus in the nose, and they are mainly treated medically. So we will give them corticosteroid nasal sprays. So you all know so many formulations are there, isn't it? So fluticasone furoate, and all that. So those topical steroids, they don't have the side effects of systemic steroids, and they are good for allergic rhinitis to control the inflammation in the nose and the sinuses. We can treat them. The acute attacks are treated by oral anti-allergics. Or if it's very severe, we can give them a course of systemic steroids as well. So many things. So again, it's a big topic. You can talk almost hours on allergic rhinitis, but I'm just touching on this so that you know what is what. Okay, another big bulk of patients, especially if, in hospitals, emergencies, patients come with nose bleeding. Bleeding nose is a big problem, isn't it? So, and common cause, maybe in a child, if a small child, say 3-4-year-old, you may be having many people, you may be knowing many child who have had nose bleeding in their childhood, or you may be having a child in your family who has nosebleed. And remember, the commonest cause in a children is picking of nose. The child must be putting his finger in his nose, and that is the commonest cause. You don't allow the child to pick his nose. The child should be fine. There are many other causes. Many a times we don't get a cause. Adults might have nosebleed very often, once big bleed, and you don't find a cause. And sometimes trauma to the nose can cause nosebleeds. Neoplasms, cancers and tumors, inverted papilloma like tumors, they can cause bleeding coming out from the nose. So many things, systemic causes, of course, if their patient has bleeding diastasis or something like that. So nose bleeding, don't panic. First thing is not to panic. If you panic, the patient runs around what to do and all that, you will have huge amount of blood. It cannot stop it. Okay, so don't panic. Patient must be sit down, press the nose, the soft part of your nose, you press it close, keep it pressed for 10 minutes. If you have ice or something, apply it on the forehead and around the cheeks. Generally, 80-90% of the nosebleeds reduce with that. If not, you might have to rush to a hospital, get your nose packed. So we put in something inside the nose. This is important. Probably we get this from the pharmacy, isn't it? A Merocel pack. So these are Merocel, they are thin cardboard like, strips, various sizes. Maybe this one is 8 centimeter. This is very small, maybe 4 centimeter or so. So 8 centimeter Merocel strip is common. But what happens, when you put it in the nose, it swells up like this. So that's the that's a surprising part. So you can insert it. So it's just like a cardboard piece. So it goes into the nose easily. But when you need to come out, it is swollen now like a sponge, big sponge. So you put drops of water in that, and within seconds, within 5-10 seconds, you can see it swelling up like that. Okay, so those are Merocel packs, quite helpful for epistaxis. Some patients may need surgery. There is a video on SPA ligation. I don't know, want to see the video? Wait, let me see if I can show you a little bit of the video as to what we do. Sorry, I'm having to change screens, not very used to it. So that's one of the things. Yeah, there. So when we are operating on an epistaxis, what we do is we can actually, one big vessel which comes into the nose is called spinopalatine artery. That comes, so we are operating into the nose. So this vessel, this one, through this foramen, it's called spinopalatine foramen. So one of the big vessels come in. So these vessels bring a lot of blood into the nose. Almost 60-70% of the blood into the nose comes through this vessel. So what we can do is we can, through the endoscope, we can go in and we can stick a clip or cautery that vessel. And when we do that, that vessel is closed, and most often, maybe 90% of the times, we can actually control the bleeding is gone. See, now I'm trying to cauterize. So that's a bipolar cautery I'm using. And I'm going towards that vessel there. I'm trying to cautery. Sometimes it is very cumbersome to use instruments inside. It's very deep inside. You can see it's so deep inside the nose. It is right down almost at that level, back of the nose. See, now we are cauterizing. I've got a good cautery there. See, that's how we cauterize, and we're cauterizing and separating. So one by one, there can be few branches. So we'll go posteriorly, gradually we'll cauterize one by one. Okay, so that's how we will probably operate, do an SPA. You can see the vessel getting shriveled and shrunken. Okay. Okay, so that's that. So we may need surgery, and that is called SPA ligation or SPA cautery. So step by step, we treat epistaxis. So I don't know, I've not done justice to rhinology. There are so many other diseases you can talk about in nose, but I have just briefly touched upon a few common things which I can think. So we're starting with a little bit of rhinosinusitis, chronic and acute, allergic rhinitis, epistaxis, little bit of polyps, little bit of infections like vestibulitis, simple skin infections. There are so many other things you can talk about. Tumors, cancers inside the nose and sinuses, so many. But I think I will leave you with all these questions. You can find out if you want to know more. If you feel that, yeah, this is an interesting thing, you can go ahead and read about these things. Any basic books. Nowadays, internet has so much of information, medical information. You can go ahead and read it. Just to summarize the nose part of my presentation, remember that nose and sinuses are interconnected as one system. Rhinosinusitis is very common. Epistaxis is often very frightening condition, and patient rush to the emergency department very often with this nosebleed, and we need to manage it well. Nasal steroid sprays, anti-allergics, sometimes antibiotics from your pharmaceutical point of view. So these are the things we will commonly use in a nasal patient. Very common. If I see, in my OPD, if I see 20 nasal nose patients, maybe in 15 out of 20, I'm writing these, preparations. I'm not writing a nasal spray. I'm writing anti-allergics or a combination of anti-allergic decongestant kind of thing. I'm writing antibiotics to some. So these are the commonest medicines in the nose part which we use. Okay, so that's that about nose. I'll quickly go on to the ear. Hope you're not getting bored. I'm just going on talking and showing you a lot of pictures. But what to do? The topic is so huge, ENT in 1 hour. So the ear, okay. Again, start with little bit of anatomy of the ear, how the ear is located on the side of our head. So that's the ear, the outer ear. It's called the pinna. Okay, so this part of the ear is called the pinna. It has a lot of landmarks. The depressions and the ridges are called names. We don't need to go into that details. The helix and the antihelix and all that. You don't need to go into that. So this is pinna. The pinna gives way to this ear canal which goes in, and it ends on the eardrum or the tympanic membrane. So this is the eardrum. Okay, but the ear doesn't end here, So this part, this part, the outer part, so the pinna, the canal up to the drum is actually called just outer ear. Then we have a part of the ear which is behind the eardrum. It is called middle ear. Okay, where you have the 3 bones, small bones which are connected to the eardrum, which helps us to take the sound vibration inside. So the sound comes and hits the eardrum and it goes through this. And the inner part, so behind or medial to the middle ear, is your inner ear. So this part is the inner ear, where you actually have the neural part, the sense organ, the cochlea, the balance organ, the semicircular canals, the utricle and the saccule, and all these nerves now which connect the cochlea and the balance organ to the brain. See, you can see that this is perforating and going into the brain. So it has to connect into the brain, isn't it? Otherwise, how will we hear? How will we maintain our balance? And remember, ear has 2 very important functions: hearing, but that's not the important function. A more important function for ear is to maintain balance. If you don't have hearing, you can still live. But if you don't have balance, it will be both ears, your balance is gone. It can be very, very difficult. Especially for animals, they need that balance system much more to roam around, to prey, to hunt other animals, rather than their hearing maybe. So more important function of ear, remember, is the balance, not the hearing. But hearing also equally important. So that's a very brief anatomy, how things are oriented inside the ear. That's the eardrum, a normal eardrum. When we look straight on, so when I am looking, I'm putting an otoscope or an endoscope and looking inside the ear. So we can see that we are looking through the ear canal. So this red all around is the ear canal. So it's like a tunnel. So we are looking through a tunnel, and the end of the tunnel is this white glistening thing. It's a thin membrane-like thing, shining white. This is the eardrum. Okay, so this round thing is the eardrum, or the tympanic membrane. And attached to that is the first bone inside the eardrum in the middle ear is called malleus. So this is the malleus, which is touching the eardrum. And then the second bone and the third bone, as we have seen on the previous picture. Moving on to common diseases. This is sometimes, we often, many times we come across this. Your pinna might just swell up like that. Okay. So we can have a hematoma or a seroma where a blood or fluid is collected in the pinna. It is often seen in boxers or rugby players, or you had a fight, some people have fought on road. They come in, the Dr. Babu, see, dekhun kiram hoyeche, kanta phule geche. And that is called hematoma of pinna. You can see there is a swelling there. Often you need to, nick that. You have to go surgical, because you can put in a needle and draw out the blood, but it will just fill up again within 1 or 2 days. So often we need to make an incision, we need to make a cut like that, drain out the blood and give a pressure dressing there. Okay, so that's hematoma or seroma of pinna. So I just wanted to cover one common condition of the pinna itself. So that's that. Now going into the ear canal. Ear canal can get infected. One very bad habit many of us maybe have as well, or many of my patients have, is putting an earbud and always cleaning their ear. That's a very, very bad habit. Never do that. That causes a lot of infection. You can see this is the ear canal, and you can see a swelling, a kind of an ulcer there. So that is called otitis externa. Okay, externa. Externa is outside. Otitis is inflammation or infection, which causes inflammation. So it can be bacterial, or it can have fungus. So this is something like, fungal, maybe candida, white fungal debris inside the canal. We can't even see the eardrum. The eardrum is back there. And all this is, it's red. The ear canal is red, wet, soggy, and full of fungus. We call it otomycosis. So all this will need ear drops, antibiotics, and things like that. Sometimes we can have lumpy tumor-like bony tumors, bony lumps, okay, inside the ear canal. If there are many, you can see that's the eardrum, and you're looking through the ear canal, but you can find there are so many bumps and lumps inside, isn't it? So see, this is a bump. So this is bone which is growing. You have heard about bones growing on your foot, a calcaneal spur or something like that, or bones going extra bone growth somewhere. So these are the bones which can grow. If they're multiple, we call it exostosis. If it's just a single bump, we call it osteoma. Okay, so this is the eardrum, this is the ear canal, and you can see there is some growth, some bump in the bone, and that's an osteoma. Many times, if it is blocking the ear canal, we need to remove it surgically. Very common condition again. It can be, now we are moving on from external ear canal into the inside of the eardrum. So the middle ear can get, it's called media, middle ear, middle for media. So you can have an acute infection of the ear, of the middle ear, an acute otitis media. And you can see that the previous one, if I go back, see the eardrum, see this is the normal eardrum, how the eardrum looks, and look at this eardrum. Okay, so can you notice that it's so red, it's congested, red. It's not looking like normal eardrum at all, So this is called acute otitis media. A lot of pus behind the eardrum, commonly seen in young children. They can have earache, they are crying, they have a ear pain, and they have and this happens from cold. So there is a tube which is connecting the back of the nose to the middle ear, which gets air inside your ear, middle ear. So that tube, so the infection might have passed through that tube and gone into your middle ear. Or you might have otitis media with effusion. So this is not an acute condition. This is more or less, a subacute or a chronic condition where you don't have pus, but your mucus-like fluid. You can see that the eardrum has got yellowish. So behind the eardrum, there is thick mucus. So if I slit open this eardrum and put a very small microsuction through this opening, we will find lot of glue. It's exactly like a nasal mucus. So you can suck out like a string, you can suck out. So you can suck out all that mucus from the middle ear, and that is called otitis media with effusion. Very common condition again. Many a times, otitis media with effusion, and they are children usually, we need to operate. As I told you, we can slit this eardrum, so we may make a small cut like that, and we can suction out all the glue and all the mucus, and we can put a button like this. This is called a grommet. Okay, again, probably will be available in a pharmacy. So grommet, these are surgical items an ENT surgeon might need. So grommets are small plastic tubes, like this. There is a hole in the center, so it allows the air to enter inside the eardrum and prevents the mucus from accumulating. So the air goes in and fills up the space. So with the air, the mucus won't be building up inside, So that's how it is. One big category, big group of our ENT ear patient is called chronic otitis media. So they are kind of ear inflammation, middle ear inflammation, which are persisting for years, maybe months and years together. And a common condition is a big hole in the eardrum. See this? See, with the normal eardrum, you remember? So the eardrum was here. What happened? What has happened here? There is a big hole. So there is little bit of eardrum on the sides. So there is little bit of eardrum here, but in the center there is a big hole, you can see, and we can see the inside of the middle ear through this hole. This is the malleus, which we could just see like a shadow in a normal eardrum. Now we can actually see the malleus because it is all open. Okay, so what do these patients have? These patients have mucus coming out of the ear. And where is that mucus coming from? It is actually coming from the nose, coming into the middle ear, and then because there is a hole, it can actually come through the ear canal outside. So these patients have on and off, they have mucus coming out of their ear. Okay, so they have a hole in their eardrum. Sometimes they may need surgery. If the hole is really troubling, we may need surgery, and that is called tympanoplasty. Again, a very common operation you will hear in a day-to-day ENT clinic, a tympanoplasty. Sometimes, and say, okay, this is the eardrum. Say I have done a tympanoplasty and I've repaired the eardrum. We sometimes see the eardrum like this. There can be scars and, white scar and mark where I have created the new eardrum. So I'll use some material and I can make a new eardrum, and the hole gets closed and the patients get much better. Their hearing improves, their ear discharge has stopped, and they're happy. Okay. Sometimes it can be more dangerous, and that is called, that may not be just a hole. So it is, see this eardrum, we can't see a hole, but you can see a lot of ulcers and white debris and things, and that is called cholesteatoma. This is dangerous. Why cholesteatoma is dangerous? Because they can eat away bone. So they can eat away all this bone, So this is the eardrum, this is the ear canal, and above the eardrum above the eardrum and the middle ear is the brain. Okay, now you can see there is some ulcer and infection which is actually in the bone, and it looks like only this much, but inside they're eating away all this bone, and that is called cholesteatoma. It can have serious complications. You can make your facial nerve go bent, it can cause a facial paralysis, it can cause balance problems, it can go into the brain and things. They definitely need surgery. The treatment for cholesteatoma is operation. And you will hear common operations like mastoidectomy and atticoantrostomy. These are the ones which we do for cholesteatoma, a squamous cell type of chronic otitis media. When we operate that, you can see that this is one post-operative picture. So this patient must have had a huge cholesteatoma. And to just make you understand this picture, I will just tell you that what you were seeing in the previous picture is only this much. This much was the eardrum. Go back to this. So this is the eardrum. So this was all having ear canal bone. So we couldn't see this. Okay, so only this much is eardrum. And if you go down, you will see this is the eardrum. And all this is drilled away bone, which we have drilled away. And all this had all this cholesteatoma and infective keratin debris and cholesteatoma, which was eating away all this bone, you know. So we have cleared away all these bones surgically, and now the patient is left with such a big ear canal. So the ear canal is drilled, and this entire thing is a cavity we call. So this is the mastoid cavity, which which we have removed all the disease from here. Okay, these are common operations which we do, right? Okay, another big chunk of our ENT patient is vertigo. You know, they are having, a reeling of head. It can be, remember that vertigo may not be only from the ear. Although if they're having true vertigo, it is often from the ear. If they're having a rotatory sensation, they're otherwise understanding where they are, how they're holding on to their bed, or they're feeling nauseous. It vertigo, and which is probably from the ear, the balance organ in the ear. But there can be many other things which patients say vertigo. You know, they say matha ghurchilo. But matha ghurchilo, if you ask them actually ki hocchilo, you will know that, oh, they meant that they were having a blackout. You know, it is not actually ghurchilo, but it was a black sensation and they were losing consciousness for some time. And that can be from the heart or from the brain and not from the ear. But sometimes, many a times, they say it was a rotatory sensation, and we get lots and lots of patients in clinic who have vertigo. I cannot tell you a lot of things about vertigo in this presentation because I just have 1 or 2 slides, and I will not do justice to this. But you should, probably you will get, if you get more interested in vertigo, go ahead and read. There are many causes of vertigo, and so many things we do to improve the patient, which includes, first of all, vertigo patients, they are very much disturbed. Their entire lifestyle is upset. They probably are not able to go to work, frightened what will happen. So counseling them is very important. Some exercises like vestibular rehabilitation is important. Medicines, this is where you all come in. So there are so many pharmaceutical options of, acute agents like prochlorperazine, cinnarizine we use very commonly. Some medicines which give for a long time, like beta histine, also a very good, anti-vertigo. So many things have come up over the years, isn't it? So many newer agents are coming up. So many medicines, and the treatment is mainly pharmacotherapy. And so there are so many medicines, and the role you all have is immense in vertigo, isn't it? And very, very few cases you might need surgery, very few. But mainly vestibular rehabilitation, pharmacomedicines, and explaining the patient, reassuring the patient is the treatment. Just very briefly, one tumor, not very common, quite uncommon, but every now and then you come across a tumor which is very serious, but it comes to us ENT because they're present with hearing loss on one side and maybe a little bit of dizziness, maybe some abnormal sensation over face, and that's called acoustic neuroma. You can see, so if I explain this picture, so this is the front of the face, the nose and the cheeks here, and the back of the head is here. And this is the sides of the head. So this is an MRI. So this is the side of the head with the ear. And you can see from the inner part of the ear, there is some white blob which is jutting into the brain, which is not there on this side, if you see. So this side is the normal ear, normal hearing nerve, and this is the abnormal hearing and balance nerve, which has a tumor. It is called acoustic neuroma, going and pressing on the brain. See, it's actually pressing and bulging into the brain. That needs, many times it might need surgery. Very small tumors may not need surgery or treatment, but many times it needs actual surgery or a radiation kind of treatment, which is called gamma knife treatment, which is again, which is a very important disease, not very common, but important, inner ear disease. Another very common disease you will hear about, again related to the ear, is paralysis of the facial nerve. So you can see this woman, can you guess which side of the face is paralyzed? Is it this side of the face that is paralyzed? Is it the right side of the face that is paralyzed or left side? It is the left side, okay? So when she smiles, it bends and goes to the right side because the right side muscles are working, but these muscles are not working. So they are not pulling it, to maintain the symmetry, they're not pulling it on both sides. It's just pulling on the one side. She can't close her eyes on the paralyzed side. So this is called facial nerve paralysis. There are many causes. One common cause is Bell's palsy, and we treat that with steroids, systemic steroids, maybe antivirals, acyclovir, sometimes some neuro facial physiotherapy and things like that. So again, a lot of roles for Bell's palsy. So that's one of the conditions which is related to our ear. Many others, but I think I have tried to touch on the important points. To summarize, there are a lot of diseases that can affect the middle ear, the inner ear, going into the brain as well. And all of these come into us, the ENT surgeons. Very, very common ear disease in our day-to-day practice. A careful history, careful examination. We have certain tests we can do, a CT scan, audiometries, tympanometries, and things like that, which help us in diagnosis. And there are so many medicines we use there are topical medicines we use in ear, antibiotic combinations, antifungals, and all ear drops. We have a lot of tablets we use antibiotics. Some diseases need steroids, some diseases needs antivirals. So many things, so many medicines and, things we can use in ear, and a lot of surgeries as well. So common surgeries, as I mentioned, okay? So that's that. Let me know if you're getting bored, I will stop. I think last few slides, just a little bit on thyroid and then we end. So quickly going on to the next topic, neck. I didn't know what to cover really, because there are salivary glands, there's the mouth, the throat, where the tonsils are, the voice, a big topic, the neck, head and neck cancer is a big topic. Thyroid, I thought maybe thyroid. So you must, you will know many patients who have thyroid diseases. So I thought probably let's talk about thyroid a little bit. So what is thyroid? It's the front of your neck. So there, as you can see, so a gland in front of your neck is thyroid, and that can be a source of many diseases. So that's the thyroid gland, Thyroid means shield. Like olden days, the warriors used to have a shield. It is a butterfly-shaped gland. So that's the butterfly-shaped gland. Back of the thyroid gland, if you turn around the thyroid, you will see there are small glands, 4 small glands, which are called parathyroids. They are also important in maintaining calcium levels in your body. Okay, parathyroids, very important as well. So your thyroid gland and your parathyroids. So most often we get thyroid diseases, but sometimes we do get parathyroid diseases as well. So a lot of parathyroid tumors can happen as well. Okay, I will talk about my part. I'm not going to the medical thyroid diseases where there is a hypofunction and hyperfunction, where we give thyroxine orally or maybe give neomercazole and things like that. I'm going to talk about a surgeon's point of view of thyroid. When I need to remove a thyroid, if they have a tumor in the thyroid, okay? So that is called a thyroid nodule. How will you know? You can feel the thyroid. That is how you should feel. So this is a patient. We have to feel for the thyroid gland. We go behind the patient and feel the gland that way. Okay, so see the patient, see the doctor is feeling with the pulp of his or her fingers. Okay, the thyroid gland, not the tip, not feeling like that, feeling like that. So thyroid nodules, they're small tumor-like lesions on the thyroid gland. Many of them are not cancer, so they're not benign. They're benign, not cancer, 95%. But some can be cancer, 5%. And it is our job to know which might be cancer, and we need to remove it. So we need to remove the thyroid gland along with the tumor with it. Okay. So, a lot of information here. I'm not going to those details. So you should know that thyroid nodules mean tumor or lump-like swellings in the thyroid gland. Okay. And some of them can be cancerous or dangerous. We need to remove them. Some might be benign. So we will do some tests like an ultrasonography, an FNSE, a cytology, and find out which is more likely to be cancerous. And thus we will remove that. If we find out, no, this is probably benign, we can let it stay inside. We may not remove the thyroid gland then. Okay. So this is a big flow chart which tells us, how we will decide in the clinics, how I will decide which one to operate, which patient to operate. If anyone who has a lump in the thyroid, I'll operate? No. Some patients will need surgery. Some will need very quick surgery and the entire thyroid gland to go out. That is called total thyroidectomy. They are patients which are probably, I'm sure that they are cancers. Some will need only half of their thyroid gland to go out. Those are patients which might be cancer. They are probably not definitely cancer, but I'll need to take out that thyroid, half of the thyroid gland, send it for histology, get back the report, and then decide on whether the other half of the thyroid needs to come out or not. So many things here. I'm not going to read out that, but I'm going to focus you on two main investigations of thyroid: a sonography of the neck. Like many other neck diseases, we use sonography very commonly, especially for thyroid. And like many other neck lumps, tumors in the neck, we use an FNSE. So somewhere here, there you will see an FNSE, where a pathologist will put a needle, take out little bit of juice from the tumor and test it under the microscope and tell us what it is. Okay. According to those two reports, I will decide what to do when we find a lump. Okay. I'm just going to show you a little bit of pictures, and we're going to talk about a little bit about thyroid operation through pictures. I'm not going to give you a lot of writings and all that. So this is a patient which I'm operating for a thyroid. Just to orient you, this is the head or the chin of the patient, this side, okay? And this side is the chest of the patient. So this is the neck, front of the neck, right? This is where we will cut. You can see a thin line which I marked the incision. So this is where I will cut open the skin and the muscles to open up the thyroid, right? I've already cut, so I made this cut here, and we are lifting up the skin now. So I've lifted up with my instruments, diathermy and things like that. And these are the neck muscles, strap muscles we call. They're in the front of the neck like that. So these red things are neck muscles. So I've cut open, I'm exposing the neck. We will also expose these muscles. We will go inside, we'll split the muscles, and we have to go inside because thyroid is not outside. Thyroid is deep inside the neck, right? So this is when we are separating these muscles. See, one of my assistant is holding one side of the muscle. I'm holding this side, and we are splitting the muscle. Okay, that is the thyroid gland inside. You can see just below my thumb, there are retractors opening up. So that is the thyroid gland, one half of the thyroid gland. And that is one important step. See, I'm tying something with this thread, the vicryl suture. That is the, so that is the blood vessel, that is the main blood supply, the superior thyroid artery, which we need to tie before we touch or do a try and cut into the thyroid. It will otherwise bleed and the patient might bleed to death. So I have to control the blood vessels, isn't it? So that is my superior thyroid artery. I'm tying it, and then I will gradually, step by step, I'll go and remove it. You can see now I have, it's quite advanced stage of the surgery. So this is the thyroid gland under my fingers. So that I've kind of separated it. Now we are in the process of removing it. One important nerve which I should not damage when I'm operating thyroid, otherwise the patient will not be able to speak. Maybe will have a very hoarse voice, very bad voice for the rest of his life. And that's that nerve. You can see that white thing going there. That's a recurrent laryngeal nerve. So this is the voice box. And I'm separate. This is the windpipe. So this here will be the windpipe from which we are separating the thyroid. This is the nerve which we need to take care of. Okay. Now almost the thyroid is out. See, this is the big thyroid lump in my hand. Little bit attached there. I will cut it off. But this is the thyroid gland. This white thing you can see is your windpipe, is the trachea. So this is the center of the neck where we feel the pipe-like structure. So that is that white thing there. And on top of that, so this is going down into the chest. And this part would be the voice box from where all this I'm talking now. So my voice box is working. So inside of this is working. And this is the thyroid gland coming out. Okay. When we close, so we have closed as if we have not done anything, very innocent. We just put suture underneath the skin and close, allow it to heal. And in around 5 days time, I'll remove this stitch. And in 3 weeks time, you can hardly make out anything has been done. It will just be like a line on the neck. Okay, it will just heal up like this. Okay, so like this structure. So that's how we operate on thyroid sometimes, So that's that. So I'm going to, this is I think my last slide, and conclude by saying that we all had known it maybe 10, 20 years. ENT is such an expanding field in US where I worked in house, I went to UK, and there ENT is among all the medical branches, surgical branches, ENT is one of the top branch there, top. Okay, because it is expanding through the nose, through the ear, through the neck. We are now going into territories or areas which we had never operated before, because now we have better instruments. We have endoscopes, microscopes, which we can see so clearly inside. These are small narrow holes, isn't it? So when through those holes we can actually see. And as I told you, we can operate on the brain even through this nose. We can go through the ear into the brain. We can operate on the neck. We can go into the chest, and it is an expanding field, very much expanding field. Endoscopes, microscopes, visualization like anything, and that's how the field has expanded. And in last 10, 15 years, ENT surgeons are doing surgeries which we would have never done before. And that's why abroad, outside India, even this field has expanded. Is one of the top, among the PG students, postgraduate students, the ENT is one of the top branches they will select. So that's how growing the field is. As I have told you several times, just a drop in the ocean, my presentation. I have not told you, I feel guilty that, ENT, as an ENT surgeon, I've not told you almost anything. It has just touched upon one or two things here and there. But I hope that I have, given you little information. I have motivated you maybe to go into details of what medicines we use in ENT, what are the ENT diseases, and you all should know about all of these. You are an equally very important colleague to us, and you will grow to be fantastic pharmacists. So you should know about the diseases, what we deal about, and then you will see that the pharmacy or the medicines, the pharmaceutical studies, such so easy, because you should know the background of the disease where we are using these medicines, and then it is more interesting, I think. So I hope I've given you a little overview so that you will go back and study. You will go back and put in a little more effort and find out about ENT, because you all are in the medical field now, and medical field is serious, and we should take this education, your medical education, very, very seriously. So whatever spare time you have, read about diseases, read about my ENT diseases. I'll be very happy. And I think a lot of your staff members will have my number. They can share you my number maybe, and if you have some doubts, you get back to me, and I'll be more than happy to answer your questions. And hope I have motivated you a little bit, and hope some of you will go back and think about this presentation as a motivation to read more about ENT diseases, right? You will have more questions, lot of questions than answers, because I've not told you anything, just here and there brief things. But I think I will conclude with that. Once again, I thank all the faculty members. They have been so kind to let me speak my views to all of you and all of your students. It is really a privilege, and I hope I'll get back sometime if you have another ENT topic someday, and I'll be very, very keen on doing that. But I thank a lot of all of you, really. Thank you so much. I've taken a lot of your time, so thank you. Yeah.
No, sir. Thank you, sir. Thank you for as a most informative and enjoyable presentation, sir. And thank you for a great lecture. I really learned a lot. And not only me, I think all the participant has gained a lot of information on ENT problems. And now we are open for the question and answer session. And to coordinate this session, I would like to invite Mr. Omlan Biswal. Over to you, sir.
Okay. Is it audible, sir?
Yeah, it is audible. Yeah.
Okay. So thank you, sir. Very much informative and knowledgeable knowledge gaining session we have got. And also the information regarding the ENT problems we have got is awesome. And your presentation is also very good, sir. Now coming to the question and answer session, sir, there are a few questions has been asked from our staff only. Okay. So coming to the first question, sir. Sir, I have allergic rhinosinusitis problem, especially during winter. So how can I get rid of that problem? Sir, if you can explain this.
See, allergic rhinosinusitis, as I told you, it's not an infection, isn't it? So it's an allergy, and it is, it is a part of you. You have allergy, and you can never completely get rid of it. Okay. So what you need to do is you need to find out what gives you an allergic rhinosinusitis symptoms. Like, if I go out, or if I clean my books, or if I go to a dusty environment or a dusty room, I immediately start having sneezing and things like that. So first thing is, you should remember, avoid such situations if possible. If you can identify your triggers like dust, or you go out, pollens, or some damp room, fungus, if you can identify, you try and avoid being in those situations. So try and avoid to trigger your allergic rhinosinusitis. Secondly, we have some medicines like, as I told you, corticosteroid sprays, the topical nasal sprays. Use one of them. They are the latest things that we have. But remember, you have to use it for several months. So use it for some months. Don't stop it immediately if you feel better. So you obviously will need to visit one of the ENT surgeons, and they will prescribe it. They will tell you how to use it. Use it accordingly. What I find among my patients, the commonest mistake is that you use it for 10, 15, 20 days. The allergic rhinosinusitis is gone. Maybe you're feeling better. You stop the spray. And then again, you get it after 1 month and you start using it for a few days. You stop the spray. No, you are probably going to do a course of nasal sprays for 3 months, 6 months. Even if you are well, only by doing that, you will stop having frequent attacks. Okay, only by that, you will probably have years, 2-3 years, that you will not have any more allergies. Okay, when you are having a lot of symptoms, you will have to take some anti-allergics along with your sprays, because the spray will not get rid of the symptoms immediately. But the tablet, have lots of tablets, acetrizine, levocetrizine, fexofenadine, whatever is your favorite agent. You will know more about all these agents. So you will have to take one of that tablet on the days you have symptoms. So if you're troubled by your nose, take the allergy medicines for 2-3 days, stop it, but continue a spray. Okay. Visit an ENT surgeon. Don't do all this by yourself, because I have told you to. So visit someone, take their, you might think it is allergic sinusitis, but it might be something little more. You might have already developed some polyps or something like that, which might need some operative thing as well. So, you visit someone, let them have a look into your nose. You might need a CT scan or an endoscopy or something. And then you can, the main important things in allergic treatment is avoid your trigger. If you can, don't go to a dusty place, or don't dust your room yourself. Minimize dust in your room, inside your office and things, and your allergic sprays and tablets.
Okay. Thank you, sir. Coming to the next question. It is from our faculty, Mr. Richik Bandopadhyay. Can polyps increase the headache of sinuses?
It's a good question, because we all have this common, notion that headache is because of sinuses. Believe me, if you come with a headache, there is probably 90-95% chance that it is not sinuses. Headache is generally not from sinuses. Okay, it is very rare to get a pain or a headache from sinuses. You can get it only when you are acutely infected. Say you are having bad rhinitis, a lot of mucus coming out of your nose, you have fever, then you might have headache and pain around your face, and that might be due to sinuses. But on and off headache, it is definitely due to any other cause. It might be migraine, it might be tension type headache, it might be a cluster headache, many other things. It's definitely not your sinuses. Polyps don't have direct relationship to headache. Polyps will not cause headache. They will cause a stuffy nose, maybe a heaviness around the nose, breathing problem, allergic, or you have a lot of mucus coming out of your nose, but rarely it will cause headache. You will get headache in a polyp when it is secondarily infected. So you have polyp and you have a lot of infection which has built in. Then you probably had a headache for a few days. You take an antibiotic or something for the infection, the headache goes down. But you will not have recurrent headache for your polyp. Then it's something else. Maybe you have a migraine or something like that, which needs to be investigated, right?
Okay, sir. Thank you. So next question from Mr. Rajashri. Sir, drug which are used for nasal consumption, if we used it excess amount, any neuronal toxicity will happen?
Good question again, because I have not talked about this in my presentation. See, mainly the drug which we don't want you to overuse is oxymetazoline, xylometazoline. Okay, so this formulation, Otrivin and all this, Xylomist, Otrivin, Zoamet, so many brand names. We always tell the patients, use it if it's a rhinitis or rhinosinusitis. I need to give it for nose block. I will give it only for 3 days, 5 days, something like that. I tell the patients, don't overuse it. Definitely, it is habit forming. It causes some structural changes inside the nose, the mucosa of the nose and the turbinates swell up permanently, and something called rhinitis medicamentosa. So it is a disease by itself, and then it is difficult to control. You can't get those patients off the sprays. Steroid sprays generally don't have this addictive thing, so we can continue steroid spray for very months, and we often give it for years as well, 1 year, 1.5 years, like that. But oxymetazoline, xylometazoline, you definitely need to stop after a few days of consumption, and we need to tell this to the patient. Even as a pharmacist, you need to be aware of this as well. If a patient is coming buying nasal spray from your pharmacy, you can also guide them and tell them that this is habit forming drug. Don't take it more than maybe 5 days, 7 days, as your doctor told you. And don't try not to sell a lot of, we should avoid selling them a lot of nasal sprays over the counter, isn't it? That can, even if you're giving over the counter, we have to warn the patient that don't use it for more than 7-10 days. Okay, so definitely they're habit forming. They can damage the nose.
Okay, sir. Thank you. Sir, the next question is from our chairman, sir, Dr. Ravindra Devnath. Sir, he has asked that during COVID-19, along with the loss of smelling sensation, sometimes there is a loss of hearing also found. So can you please explain what is the reason behind it?
See, COVID-19 is such a new disease. We don't even know the reason behind, we don't even know for sure the reason behind the loss of smell. Loss of hearing is very rare compared to loss of smell, which is much more common. Okay, so from whatever recent knowledge that we had, you can think of COVID-19 as not one disease. Okay, so COVID-19 is like a syndrome. So what is a syndrome? The difference between syndrome and a disease is that the syndrome has many different presentations in one disease. So COVID-19 has neurological presentations. Of course, it has pneumonia, upper respiratory infection, neurological things like, as you said, loss of smell and taste. Then GI presentations, you have gastrointestinal presentation. So all this is happening because of that one virus. Okay, you get infected by the virus, and that virus, we don't know how, and the entire pathophysiology is not yet clear, but we still don't know why, but it causes a lot of effects. It causes effects on your nerves, on your nose, on your pharynx, on your lungs, on your GI system as well. So from what I have seen in my clinical practice, loss of smell is quite common in mild to moderate kind of cases of COVID, and it is especially common in young patients. In my practice, have found more worldwide, but anosmia due to COVID, I found it more in females, especially young females, young patients who have had mild disease that didn't need hospitalization, but they have had a lot of anosmia, and they come to me in the clinics with anosmia. Okay, even hearing loss, sensory neural hearing loss, we can't really put it down to COVID. We have not definitely had that evidence yet, but you can have sudden, and even today, I was getting a little bit late for my presentation because I was in OT with one patient with sudden sensory neural loss hearing. So you can have sudden sensory neural hearing loss. You can think of it like in a layman's term as a stroke, or like a cerebrovascular accident affecting your ear. One fine day, suddenly you can see that you're hearing less. Okay, and that is an emergency, an ENT emergency. I didn't tell you in my otology presentation, but that is one thing which is an ENT emergency. That ear you can be deaf in that ear for the rest of your life if we don't quickly do something. Okay, even if we quickly do something, there are 30-40% of the patients will be deaf for the rest of their life. Okay, so that usually happens on one side, just like a stroke or a cerebrovascular accident. It can happen on 1 year. You can suddenly go deaf on 1 year. There are many causes for that. There are vascular causes, viral causes, and COVID-19 is one of the viruses that can cause that. Okay, exact mechanism we don't know. It can be related to what the evidence presents. It can be related to a little bit of vasculitis and the vascular, because the cochlea is an end artery system. What it means is that there is one small tiny artery which is going and supplying blood to the cochlea. It gets only blood supply through that artery branch. It doesn't get many anastomosing, many blood vessels coming from everywhere and supplying cochlea. So if your that one tiny blood vessel is blocked, the cochlea will not get its blood supply and it will die. And the cochlea and the hair cells, small cells inside the cochlea, they're very sensitive to hypoxia, very sensitive to low oxygen concentration. Okay,
Yes.
so if you get hypoxia there, you will develop some amount of sensorineural hearing loss for sure. So these patients can present with hearing loss. They can present with tinnitus. Many of my patients have come with post-COVID tinnitus, where they have noise in their ear, and so probably those are the mechanisms. But again, it is something which we are talking is research-oriented, evidence-based, where we are still evolving with our theories. I am telling you this today. It is just on assumption and some things we have observed. 1 year down the lane, we might think, oh no, COVID related hearing loss was completely different. I might say, I might be telling you that. So that's how it is.
Okay, sir. Okay, thank you, sir.
Okay, thank you very much
Thank you,
for
sir.
your
Thank you.
beautiful deliberation and scientific information. Now, this ENT section, very important for control of the COVID spreading and the COVID diseases. So, our pharmacists and pharmaceutical personnel who are designing the drug and fabrication, they have the thorough knowledge about this ENT section. Because now in the world has also asked us to put on the masks and other personal hygiene is there, so that we can control this disease on the spreading. So again, we are coming to the ancient life, that is personal hygiene to be there, then infection will be less, then we will have the good health. Really, it is a wonderful session.
Thank you,
Because
sir. Thank you.
something most of the students we are also not knowing. We are designing the drug, nasal drop, nasal spray, etc. Actually, where it is effective and how it is working, this is to be known first, then the design of the drug. And one of the thing is there is a very very thin layer between the nose and brain. Whenever anything comes in the nose, it will directly hit to the brain without going to the circulatory system or heart and others. So we have to design the drug cautiously. That is, it should be non-toxic, it should be hygienic, because it will not pass by the liver bypass. Liver bypass protection will not be there. So this is a wonderful session in the COVID situation. Our students, staff are sitting in the room at their destination, but they are day by day doing the regular online classes. Now in the globalization system, world is in our own hand, in one ball. So this is, I must say many thanks to Dr. Chatterjee as he came forward to our institution and delivered the lecture, and staff, our students, and other very good. Thank you very much.
Okay. Okay, sir. There are some few questions. Sir, the next question which is coming is from our Bhaktipada Barik sir, Dr. Bhaktipada Barik. So he has asked that compared to conventional drug therapy like nasal drops, ear drops, or mouthwash, can there be any novel drug delivery so that local bioavailability and efficacy of drugs can be improved and frequency of administration be reduced? Sir, if you please explain.
Yeah, it's a good question, but that's, I think, something which my you guys will be knowing probably more. Local, if I talk about, say, topical steroid sprays, that was developed because your systemic steroids are so have a lot of side effects. And if you take a topical steroid spray, that probably acts on the nose, so their bioavailability is very less. They don't get absorbed systemically so much, and that has a good efficacy as well, because I can give a very small amount of dose compared to a systemic steroid. I give a very small amount of dose in form of spray, and I choose such agents that they won't be absorbed, or even if they're absorbed, they're destroyed by the first pass metabolism or something like that, so their bioavailability becomes very close to zero. And those type of medications has a big benefit over systemic medications. So something like that we might start thinking and developing, like in migraine. There are you all know about triptans, like say sumatriptan in migraine. So a patient of migraine often has very bad gastric emptying, because when he is having a migraine attack, one thing that happens to him is his gastric emptying is also delayed. He has got a lot of nausea. So many of you must have had a migraine, and you will have headache, you will have nausea, you'll have vomiting. And one thing that happens during a migraine attack is your gastric emptying is delayed. So if you're giving him a tablet, so the patient is having a migraine attack, he takes a sumatriptan or some triptan or something, maybe an analgesic or something. His gastric, the medicine stays in the stomach. It is not absorbed. So the bioavailability is seriously deranged, and the patient doesn't get relief from migraine. So what has been developed for that? You probably have a nasal spray, or a nasal powdered form of sumatriptan. So if a patient is having a lot of nausea and vomiting, you don't want to give him a tablet. You give him in the nasal form. You do have subcutaneous injections of sumatriptan. You can inject it subcutaneous, and that can give a quick effect. Instead of giving him a tablet, give him a tablet, it stays in the stomach, doesn't get absorbed. Those are the things which have developed. But I can't think of ear drops or nasal drops where we can think of something else, because ear drops and nasal drops, what we are mainly focusing is the local action. When we are giving it in drops, we don't want them to be absorbed systemically. So it is the topical action, which we are interested in. And so if you want a topical action, drops and sprays and creams are good medications. So that's how it is. But when you are giving systemic tablets, we might always think of better ways of giving. Instead of giving a tablet which will be absorbed in the entire body, we can give something like a patch or something like a spray or something like that. And that's exactly what we do in allergic rhinitis. We don't give them systemic steroids. We give them topical steroids, which don't get absorbed. Even if they get absorbed, they get destroyed very quickly. So they don't have any side effects, the systemic side effects. At the same time, we are getting all the one of the good effects of the steroid on the nose. Yeah.
Okay, sir. Very good, sir. Sir, next question, and it is related to COVID-19. And sir, child nasal spray, what is coming to the market for COVID-19? How much it will be effective for children, and whether it has got any sort of side effect? If you have,
I have no idea. I don't know. Maybe you guys will tell me how much effect it has. I have no experience. I have not seen the literature as well.
Okay.
So hopefully it will have a very good effect, and all our children will be protected. And I don't know. We will probably wait and watch. I don't know.
Okay. Yes. Hope it will show some better effect.
Yeah.
Okay, sir. Sir, question from our Soma madam. That's what happens actually in mastoidectomy.
Mastoidectomy. How to start? I don't know. Mastoidectomy, is an operation we do where, if you have a bad ear for years, you have an eardrum, and the eardrum is probably infected. So, but there is infection going across your eardrum into the bone behind the ear. So this part of the ear is the mastoid. Um, Now the mastoid, is not a solid bone. It has got small pockets of air. It's like a beehive. If it's like a beehive. So there is the middle ear, and all these small air pockets in this bone. So this bone around at the back of the base of the brain. So this bone here will have all these small air pockets. They all communicate or connect to the main middle ear cavity. So main part of the middle ear, which is behind the tympanic membrane, as I showed you in the picture. So what happens? So your ear disease now spills over into this bone, which is behind your ear. So that is mastoid. Now what we do is we operate. Often we can go behind the ear. So we cut the ear like that and go behind, or I can also go through the ear canal. And then, there are incisions I will make inside the ear canal, which will give me access to the bone. So this bone at the back of your ear. What I need to do is the bone, as I told you, inside the bone, there are small pockets of air, like a beehive. So small cells like that. So what I need to do is I need to drill this bone, go into all these air spaces, and these little air spaces will be filled with disease. It can be pus, it can be cholesteatoma, it can be things like that. So this disease, I will drill out, and as far as the disease goes, I will drill till, say, the lower part of the brain, so till the base of the brain, till the facial nerve, which is also going through the mastoid bone. So till the facial, I reach the facial nerve. So I will very carefully go around the facial nerve. I don't want to drill into the facial nerve, because then the patient will have a crooked face for the rest of his life, and maybe will curse me for the rest of his life. So I don't want to do that. I don't want to drill into his brain. Then I'll create a complication. So I will keep all these landmarks, and I will drill into this bone, which is the mastoid bone, and try and take out the disease, remove all these pus, cholesteatoma, things like that. And as much as possible, I reconstruct the bone and allow the eardrum and the skin, which is in the canal of this ear canal, to heal up and cover this raw bone. Usually in few weeks time, 2-3 weeks time or 4 weeks time, the bone heals up. It gets covered with skin. If we have done a good job, it gets covered with skin and the ear becomes dry. Okay, so now the disease which was there inside the bone, which was hiding inside the bone, and it was spreading, inside the bone and probably going towards the brain or facial nerve or balance organ. Now I've removed the disease from inside the bone, covered the bone, and allowed the skin to grow over that bone and become dry. Okay, so I don't know if I'm clear. When I am speaking, I can visualize, because I operate like that. I can visualize, I can see what I am doing, but it is difficult for, if you have attended a mastoidectomy operation or something like that, you will probably visualize that what was being done. But I recommend that if you are interested in mastoidectomy, there are a lot of materials available in the internet. I've just told you, I've tried to explain it best possible I can with nothing in my hand, just with fingers. But you can go back, read up, see pictures. What is mastoid bone? How how the ear infection goes into the mastoid. Then you'll probably understand, okay, how you'll operate, get the disease out of the mastoid, and make a new mastoid bone there, as much as possible, and cover it with skin and allow it to dry. And then you have, your ear canal will actually be a big wide ear canal, because we have drilled all that bone from there. So, hopefully that has explained.
Okay, sir. So a question from Amriya Sarkar. He's asking that, sir, how an ENG is related to vertigo or carcinoma?
Okay, Amrita, ENG is not, I don't think it's related to carcinoma, it's related to vertigo. Again, how will I start? I don't know. To tell you about ENG, the full form is electronystagmography. Now, what happens? Not taking much time, because we are already very late into night. What happens in vertigo? We have something called nystagmus. Now, if you look into a patient's eyes, you will see the eyes are moving like this when they're having a vertigo. One of the main function of the balance organ and the brain is to keep our eyes fixed when we are looking at something. Say we are going in a car, I'm looking at something, my head is moving this way, that way, every way, but my balance organ is allowing my, is neutralizing this motion. You know what I mean?
Yes, yes.
See my eyes, if my eyes are straight, like
Yes,
looking
very good.
straight like this, but my head is moving this way, that way, but my eyes are not moving this way, that way, my entire visual field is not going like that. It's not moving along with the motion of the car or motion of my walking. Why doesn't that happen? Because when both my balance organs, even if my head is moving this way, my eyes are actually moving the opposite way. You get the point? If my head is moving that way, if I'm looking at you, when my head is moving left, my eyes are moving right. When my head is moving right, my eyes are moving left, because I'm keeping my vision fixed on you or fixed on the object. Okay, my head is moving up, my eyes are moving down. Okay, so that way, so it gives an opposite movement to the eyes, and that is from the balance organ. If you don't have your balance organ, your eyes will move with your head and you will not be able to fix your vision. So when you are having problems in your balance organ, because the eyes are so much related to your balance system, if your balance organ is misfiring, your eyes are showing some false movement, and that is why you're getting the vertigo. You're opening your eyes, the room is not moving, but your eyes are actually moving this way, that way, and you're seeing the room is moving. Okay, and that movement is called nystagmus. So this nystagmus, or the eye movement, is actually a measure of what is happening in your balance organ. You understand me? Something wrong with the balance organ, we can't look into your balance organ because your balance organ is deep inside at the base of your brain, but we can get an idea what is happening in your balance organ by looking into your eyes. If we see the eyes are moving this way, we know, okay, which balance organ is affected or something. Where is the fast movement? Which side is the slow movement of the eyes? Or the eyes are moving this way, or is it moving in a rotatory way? There are so many types of nystagmus. Measurement, electrical measurement of this nystagmus is possible through machines, through computers. So they fix wires, like ECG leads on your eyes, around your eyes, and one neutral and something like that, and give us many things to look at on computer screen. And it tests the balance organ. You're actually testing the balance organ, but you're testing it through the eye. And you're recording this movement, which is nystagmus. In a normal person, you will get a specific pattern of movement. If there is something abnormal wrong with your balance system, right side or left side, you will get some different patterns of eye movement. So this is electronystagmography. So you are measuring the nystagmus, the electrical variations, electrical potentials due to your nystagmus movement of the eye in a graphical form. You have a video nystagmo, VNG as well, a video nystagmography, where we'll record the video of the eye movement, and that can actually give us a lot of analysis of what is happening in your balance organ. It is one of the tests we very commonly use in our day-to-day practice. In our vertigo practice, ENG is a very common test, and we often do to diagnose what type of problem, where in the vestibular organ is the problem, what is the problem the vertigo patient is having. Okay, so again, hope I have answered you, but VNG is something which when I was doing my ENT postgraduate, my MS ENT, I was having trouble understanding. Okay, so it is a very, very complicated thing. So you might go up and read a little bit about ENG and what it is, but it is very complicated. Okay, balance system is very complicated. So to just give you that brief idea about what is nystagmus and what is nystagmography, the measurement of nystagmus, and how and why it is connected to the balance organ. So if you know that much, I think it is good enough, because even non-ENT doctors will also probably won't know a lot about ENG. Neurologists and ENTs will probably know a lot about ENG, but it is difficult concept to understand. Very, very complex things, physics-like things happening. So that is that, yeah.
Sir, coming to the last question of this session. Sir, how to clean ears without visiting ENT specialist at home? Is there any procedure?
There is a very good way to clean ears at home. And you all will be, very happy that I'm sharing this information with you, because it's a common problem. You need to clean your ears at home, isn't it? So one very, very good method to clean your ear is not to touch your ears at all. Okay, that's the best method you can keep your ears clean. Don't touch it. Don't put earbuds. Don't put hooks or anything in your ear. Okay, that's the best method, believe me. Your ears, or so for instance, any animal's ears or any human's ears are built in such a way that the wax or any debris that accumulate always comes outside. Okay, there are small hairs inside the ear canal which push the debris outside. The moment you put earbuds or things, it starts going in, and that's the time when you get trouble. Okay, so the best way to keep your ears clean is don't touch your ear. What if you have a normal ear, if your ears are not diseased, you can put little bit of oil once in a while. If you good if you select olive oil, which we put in body, during winters. So you can put olive oil that will keep the ears lubricated. Remember when we were small, our mothers or grandmothers used to put oil in our ears, and that is a very good practice. If you don't have a hole in your eardrum or otherwise not diseased ear, if you have a normal ear, go ahead, put oil in your ears. That will avoid sticky wax or things getting stuck inside. But the moment you put anything inside to clean it, that is the time you will need to visit an ENT surgeon one day or the other, for sure, because you will get wax pushed inside into a place, into an inner part of your ear canal, from where it cannot come out outside on its own, and neither can you do it at home from outside. So the best method, believe me, is don't do anything to your ears. Even if you have a very itchy ears or something, visit a doctor. We can provide some creams and things to apply in your ear canal to reduce that itchiness. Some patients have a lot of itchy ears and they keep on putting earbuds and itch their ears. Don't do that. That's a bad habit. Because more you do that, more you will feel like cleaning your ears. Every now and again, you see a earbud or see something, pen or a pencil or something, you need to put it in. And that's a bad habit that predisposes to a lot of, I showed you, remember, otitis externa. That your ears will stay clean.
Okay. Thank you, sir. Thank you for this interactive session. And now I will hand over the stage to Dr. Gunjan Sarkar to kindly felicitate our respected delegate, Dr. Sabyasachi Chakraborty, sir, with a certificate and a memento. Hand over to Gunjan, sir. Sir, over to you.
Okay. Thank you, Omlan sir. Thank you. Thank you, doctor, for your nice interaction with all the participants. And we have a request for you that could we meet again in any other session?
Sorry, I couldn't hear you. It got, my network was bad. It got stuck.
Actually, we have a request for you, sir. That is,
Yeah.
could we meet again in any other session?
Yeah. Why not?
Okay.
Welcome.
We will take some few
I
minutes from you.
believe your students are seeing this presentation and they're,
Yes, sir.
they're probably following the presentation. Yeah.
Yes, sir.
Yeah. So yeah, I'll be glad to do that because a lot of people, young minds.
Okay, we will take some few minutes
they
from your
need,
busy schedule, sir.
I am only ENT and maybe allied topics.
Okay, sir. Thank you, sir. Thank you.
Because guidance, because they're locked up at home and they're not even able to come to college. So we should have sessions like this. Sure.
Okay, thank you, sir. Thank you. So please allow us for felicitation and awarding virtual certificate to you, sir. Omlan, sir, please.
Thank you so much.
Welcome, sir. Welcome. Sir.
Thank you.
Thank you. Welcome, sir. Welcome.
This is a small memento from all of us, sir, from our
Okay.
BT Bharat Technology
Thank
family. We are trying to gift you this in a virtual platform. Okay,
Thank
this
you
is
so much.
only for you, sir.
Really appreciate it.
Okay.
Thank you, sir.
Okay.
Thank you very much. Many thanks, sir.
So
Now
good
we-
night to you all and something out of it. And yeah, we will meet soon, maybe. Yeah.
Okay, sir. Sure, sir. Sure. Good night, sir. Good night, sir.
Good night.
Good night.
Good night, sir.
Okay, now we are in the end session of today's webinar. Now I would like to request Mr. Sandip Kumar Pahari to deliver vote of thanks to all the participants. Mr. Sandip Kumar Pahari, sir, over to you, sir.
Yes, thank you, Gunjan, sir. Am I audible?
Yes, sir. Yes, sir. You are audible, sir.
Thank you, Gunjan, sir. Good evening, everybody. On behalf of organizing committee of today's webinar, I want to convey my thanks and gratitude to today's eminent speaker and renowned Dr. Sobhyasachi Chakraborty, sir. Bharat Technology is really happy for his presence and his informative and elaborative speech and discussions with us. Then I must thank today's chief patron, Professor Dr. Robindra Devnath, sir, for his inspirative attitude to organize such webinar. My special thank goes to the principal and vice principal, sir, for their presence and enthusiastic thoughts towards today's program. After that, I must convey my sincere thanks to today's moderator Gunjan sir and all the committee members headed by Soma madam to actually make the program a success. With it, I should convey my gratitude to the pioneer of our profession like Professor Dr. B.B. Bari for his gracious presence and incorporation in today's program. Lastly, I should not forget to offer my thanks to all the participants and beloved students of Bharat Technology for their patience hearing. Thank you all once again. Here I conclude today's session. Good night.
Thank
Okay.
you, sir.
Thank you, sir.
Thank you,
Good
sir.
night.
Thank you, Pahari, sir. Good night to all.
Mhm.
We will meet again very soon in our next webinar.
Okay, thank you.
Thank you, sir. Thank you, Chairman, sir.
Thank you.
Thank you.
You have presented very nice way. I am very much happy that today seminar there is no disturbance and no microphone, nothing was disturbance. Everything is tip top.
Yes.
You
Thank you,
Varsad
sir.
and Biplab,
Thank you, sir. Thank you.
you are
Thank
so much energetic that whenever you decide to do this, you have done.
Thank you, sir.
Okay. Thank you, sir.
You ask
Thank you.
all
Good
the
night.
teachers to conduct the online classes because university examination will be knocking at the door.
Yes, sir.
Mm,
Thank you.
Thank you.
Thank you, sir.
Thank you. Good night, sir. Good night.
Thank you, sir. Good night.
Okay. Thank you, sir.